Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Teledyne Pulse. Today we have part 2 of a 2-part series with Dr. Allison Nazinitsky. This has been excerpted from a webinar we had back in February, where she talked about infectious disease telemedicine in rural and regional hospitals. If you'd like, you could go back to our previous episode and listen to part 1. If you'd like to follow along with the slides as she's presenting, those can be found on the Teledyne website. Just go to teledynehealth.com, look for resources in the top menu, and pull down to webinars.
So this is my 4th case. This is a 62-year-old male, has history of diabetes, hypertension, chronic kidney disease, peripheral vascular disease, and a right foot ulcer, was following with podiatry for 3 months. And he presented to a clinic at a critical access hospital with worsening pain in his right foot and cellulitis. The photo on the left was an outpatient photo from his podiatry clinic. And then the photo on the right, the orange around it is part of his dressing. But if you can see, there's some purple, kind of darker, dusky looking hues in his arch of his foot. He has an interesting history. He's been on chronic suppressive doxy for some sort of broad chronic infection, but we didn't have much history on that. It had been 20 years ago. In clinic, his blood pressure was low, 88/60. And then they had checked labs. His white count was up to 18 and his creatinine was up to 2.06 from his baseline of 1.4. So as I was called, they had already ordered a foot film, and then it hadn't been read until I was about to go see him. And I saw him probably within 30 minutes of being called. And so they are reading some gas in the tissue of this foot. And so once that came back, as I was talking to him, I ordered a stat tib-fib film to kind of see how extensive the gas was in up his leg. And so they were doing the film as I was interviewing the patient. And so I was talking to the patient, and he's this very, very stoic man. He doesn't want to be in the hospital. He's upset that he's even admitted right now. And then I'm telling him, hey, can you stand up, bear weight on your foot? Let me see how you can walk on it, because I just saw this gas, the gas had just come back, and he couldn't bear any weight on his right foot. And I tried to reiterate, can you normally bear weight on your foot? And he says, yes. And somebody that has chronic neuropathy in their foot to now not be able to bear weight is, very much pain out of proportion. So in ID, pain out of proportion, necrotizing infection, they go hand in hand. So this patient had definite pain out of proportion, even though he's stoic sitting there, I want to go home. So this was actually a CT scan after transfer. You can see all the black in here is all gas in his tissue. So from the foot up through below the knee. And once we started him on broad spectrum antibiotics, but we definitely transferred him immediately for surgical care. And this all happened really quickly. So we kept him NPO. I was able to communicate with the infectious disease doctor that was going to be seeing him at the tertiary care center. We got a hold of the admitting hospitalist team and and the surgeon. So everything was streamlined, and he actually went straight to the operating room at that point, and had, necrotic tissue and muscles in the deep posterior compartment. His blood cultures remained negative. He ended up growing strep anginosus and group B strep. But I wanted to highlight this case because it's a sort of a bread and butter diagnosis that we see, but dealing with pain out of proportion, and then helping with the transfer process, because I also cover at this tertiary care center. We were able to work as a team, the primary care doctor, myself, and the admitting team, to get this patient expedited treatment as if he presented to the ER there. It was a seamless transition of care, which oftentimes in our healthcare system, there's a lot of fragmented breakdowns of care. But this allowed for really streamlined, expedited management of this patient. So, okay, this is my 5th case. I'm going pretty fast here, but I wanted to get through a lot of cases. 79-year-old female. She has a history of squamous cell carcinoma of the vulva. She had a hemivulvectomy and radiation a year prior, and she's coming into a critical access hospital ER with left-sided chest pain that woke her from sleep. She had associated cough that made the chest pain worse. And then her only real other medical history is that she had recurrent MRSA boils and abscesses and had multiple INDs. In the ER, she was very stable. vitals wise, and her labs were pretty unremarkable. Her procalcitonin was negative and her D-dimer was elevated. Her viral testing was negative, and this was her chest x-ray, which was read as normal. And then this is her CT chest. So they did a CT chest mostly because of her elevated D-dimer, and shows bilateral cavitary lung lesions with a differential including septic pulmonary emboli, and then atypical infection and metastatic lesions. So anytime any image is read with a cavitary lung lesion or septic pulmonary emboli, that's pretty much an automatic ID consult. I think everybody's always calling us for, oh, they have a cavitary lung lesion or septic pulmonary emboli. So this is a very, very common call that we get. This lady did not want to be admitted either. And they were going to possibly transfer her actually to the tertiary care center from the ER, but she was very stable. And so I got consulted, and Telepalm got consulted on her, and we were able to see her and assess her at the critical access hospital. So we got blood cultures, sputum cultures, echo. She remained afebrile, very stable. I had very low suspicion for bacteremia, even with her MRSA history. So we got every test ordered and in the lab, and then she actually went home the next day. I did place her on doxycycline and Augmentin empirically pending all these cultures. And then pulmonary was able to arrange her an outpatient IR biopsy 4 days after discharge. So that's really quick, which was awesome for her. And she was very happy. Her and her family really did not want to be admitted. They wanted to do an outpatient workup. And then unfortunately, it did show squamous cell carcinoma. But this was a success because first off, she didn't want to be in the hospital, and we were able to do all of this as an outpatient. So we reduced her exposure to the hospitals, and we're able to keep her at home throughout, this process instead of being out of town and at a different hospital throughout the workup. So this is my last case. This is an 81-year-old female. She has hypertension, AFib, recurrent UTIs, and she has a history of recurrent C. diff. She had 6 episodes, and she even had a fecal transplant in 2020, which put her into a remission. So she had not had any episodes of C. diff since 2020's fecal transplant. And she comes into the critical access hospital ER with sepsis, altered mental status, and diarrhea. She had recently been treated for a URI with azithromycin, and anytime she goes on antibiotics, she's placed on oral vancomycin, and then they continue it 5 days after completion. And this was just her primary care doctor and I guess her previous ID doctor from 2020 that had made this recommendation. So after she completed the PO vanc, is now when she's presenting with altered mental status and diarrhea. But 1 day after she completed the vancomycin, I'm sorry if that's confusing. I tried to make this as clear as possible. But 1 day after she completed the vanc, she actually started having diarrhea. So she was so worried. So she came to the ER and had negative C. diff testing. In the ER this time, she had a UA with 10 to 14 white cells. There were some squamous epithelial cells. And this time her C. diff testing is positive, toxin, antigen, and PCR positive, like true C. diff positive, which normally in the guidelines, you don't repeat C. diff testing if they've done one within 7 days. But it was, she's having profuse diarrhea, over 10 bowel movements, really loose diarrhea. So her family was very nervous about her having C. diff and being at a smaller hospital. And so they were really pushing for getting her transferred for ID consults. And then they really wanted her to have another fecal transplant. And then she had been started on ceftriaxone for UTI, and her family was worried that her altered mental status was actually from a UTI this time. And they've been very educated about not being on antibiotics for asymptomatic bacteria. So they really wanted her on the ceftriaxone too. So they were very involved with this patient's care. But her hospital course, I stopped her ceftriaxone. She's having 10 bowel movements a day, had no symptoms of any sort of urinary dysuria. So I just said, we got to stop the ceftriaxone, continue to run oral vancomycin. And I didn't do fidaxomicin because of her prescription coverage. And then we ended up doing a CT, showed pancolitis, and then she continued to improve on oral vancomycin. And then this is, we were able to arrange for her to have bezotoxumab, which is a monoclonal antibody against C. diff, which, surprisingly, she had never gotten any doses of this, even though she's very high risk for relapse. So we were able to arrange for her to get a monoclonal antibody while she was still on the vancomycin. And then they had never done a fecal transplant at this hospital, but I was able to arrange for her to have a fecal transplant at this critical access hospital 24 hours after her last dose of vancomycin. And once I described the way we were going to do this, the family was so happy that she didn't need transferred. She's 81, pretty frail, and they were so happy that all of this could be done locally. And so that was the summary of that story, is just how we were able to do some very complicated treatment at the smaller hospital and also provide the reassurance the family needed. So in summary, patients can be kept locally for ID expertise with tele-ID. I do believe it enhances the patient's perceptions of the local hospital to be able to offer these services. Consulting at these critical access hospitals can help expedite a workup, can streamline the transfer process, and even streamline the discharge planning process. We can keep things within the same system and follow-up testing locally so that the patients don't have to travel an hour or two away for things like CT scans, MRIs, infusions, and even fecal transplants. And then tele-ID is beneficial also at the tertiary and regional referral centers because of the shortage of ID doctors covering weekends, covering vacations. That we can help on all these complications where, the hospitalists or surgeons may not feel comfortable managing. So I'll just open it up for questions now. Thank you, everybody, for joining.
Well, thank you, Dr. Nez. Those were fascinating cases. First question I have, on the patient that had the necrotic tissue in his foot and the gas in the leg, were like Dopplers done locally, and could the nursing staff feel a pulse in that leg?
So he did have a pulse. It was diminished, but he did have a pulse. So there wasn't like acute limb ischemia on top of everything, but he did have a pulse.
On the C. diff case, is that a normal course, preventive course, like when someone goes on antibiotics to do like Vanco as kind of a backup, or is that a little outside normal?
So it hasn't been studied to prevent C. diff in somebody that's got recurrent C. diff. It's sort of a expert opinion, and a lot of doctors will put patients on prophylactic vancomycin while they're on antibiotics. Yes.
Okay. Just a comment. Just such a huge advantage to have the services for patients. We've seen patients transfer as far as 6 hours away sometimes for osteomyelitis, and it's just a huge benefit to help those folks stay close to home, close to family, close to their support system. It is really an amazing service, especially for critical access hospitals and for hospital, like you said, those regional hospitals where maybe they don't have 24/7, 365 ID support. Do we have any other questions? Rachel says everyone should have tele-ID.
Thank you. I agree. Everyone needs tele-ID.
This has been fascinating stuff. I think of you as a detective, looking at all the clues and putting the clues together in order to try to come up with a diagnosis. And it's pretty fascinating work, and we're glad to have you partner with us.
Yes. It's great just being part of the team. And like I said, all the hospitalists that call me and surgeons call me, and it's really collegial, and really the patients at the foremost front of our decision-making and discussion. So I think that's just everything I went into medicine for. So,
well, thank you everyone for joining us. This will be posted later on the Teledyne website. So if you want to watch it again or go back and review some of these cases, I'm sure that everybody could benefit from walking through them again, because you put everything together really nicely.
Thank you. Thank you.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.